Can we start?
Yes, sir.
Mohan, please proceed.
Yes, yes, sir. Good morning, everyone. I'm Dr. Mohan Sai. I'm second year DM resident at AIMS Jodhpur. And today's seminar topic is on approach to neuromuscular weakness. I would like to thank Gansham sir and Srinivas sir for giving me this opportunity. So, the agenda for today's seminar would be we will have a small introduction, and then we would like to go in a first approach would be non-emergent approach, where we would like to discuss about some signs and symptoms, putting it together in the form of syndromes, and then we go with some investigations that will help us, and then we talk about how we manage these patients in emergency, and some new things which also are important in this management. And last but not least, we'll talk briefly about three important cases in the last. So to begin with, introduction, like neuromuscular disorders, neuromuscular weakness is a vast topic, and the presentation in ICU and its management is tricky. So in this seminar, we would like to talk about acute versus subacute. We will leave the chronic causes of neuromuscular weakness aside. We would talk predominantly about non-traumatic causes of neuromuscular weakness, and sometimes this neuromuscular weakness would be an upper motor neuron lesion, a mix of upper motor neuron and lower motor neuron lesions. But we predominantly talk about lower motor neuron lesions, and something before and after ICU admission. Before ICU admission, it would be predominantly myasthenia. Then it would be Guillain-Barré syndrome. But after ICU admission, predominantly it is a ICU-acquired weakness. So with this introduction, like the common diseases we encounter under the banner of acute neuromuscular weakness is Guillain-Barré syndrome, myasthenia gravis, organophosphorus poisoning, snake bite. We think elapids are commonly cause this acute neuromuscular weakness. But to surprise, vipers do cause in good number of patients this acute neuromuscular weakness. One should be aware of it. And a critical illness, myopathy or polyneuropathy, and inflammatory myositis. These are common encounters, common cases which we see in the practice. But one should also remember that acute neuromuscular weakness can be caused by tropical fever, tropical infections like dengue, rickettsia, leptospira. Hyperglycemia can present as acute neuromuscular weakness. We have few case reports where it has presented with hemiplegia, hyponatremia, hypophosphatemia, severe hypothyroidism, and certain drugs. They all present as acute neuromuscular weakness. So now we talk about certain signs and symptoms, and how we approach to differentiate these syndromes. So the predominant symptom would be weakness. People tell that I'm feeling weakness in my limbs, but you need to differentiate it from the fatigue or malaise. And in order to differentiate, so one need to understand how this weakness is impacting the routine activities of the patient. So, like for example, in proximal weakness, there would be difficulty in combing hair, difficulty in rising from the chair. Then, when it is a distal weakness, we would be having difficulty in typing, or if it is in the lower limbs, there would be frequent falls. In case of ocular weakness, there would be a double vision, drooping of eyelid. Bulbar weakness, there would be difficulty in swallowing. So there will be difficulty in handling secretions in the oral cavity. So, and once the weakness progresses and involves truncal muscles, there would be breathlessness. Sometimes they are also associated with sensory symptoms, tingling, numbness, pain, and also with autonomic symptoms such as profuse sweating, dry mouth, etc. So these are the basic symptoms with which a patient presents to us. And then, so once patient presents to us, and then we need to dig out the history, as in when was the last known well. Not just this is applicable to the stroke, but it is also applicable for the acute neuromuscular weakness, so that we can decide upon whether it is acute, subacute, or chronic. And once we got to know that this person is having weakness, and we would like to know what is the impact on the daily activities, how is it progressing? So patient has presented with weakness, and what is the progression? Is it rapidly progressive? It is slowly progressive, and differential diagnosis varies based on it. And certain causes of acute neuromuscular weakness would have a possible inciting events or triggers, like infections in case of Guillain-Barré syndrome, and also factors associated with improvement or worsening of weakness. So in myasthenia gravis, when you do activity in repeated activity, so there is a fatigability, and it is associated with worsening of weakness, whereas the rest will improve the weakness. And also associated symptoms, we would like to see whether there is change in voice where bulbar involvement is there, involuntary movements like fasciculations in terms of motor neuron disease, sensory and autonomic symptoms in case of Guillain-Barré syndrome. Now, I mean, for us, weakness is important, but then breathlessness is equally important. Two major symptoms in acute neuromuscular weakness. So we would like to know about the onset, then severity, its duration, and factors associated with improvement or worsening of weakness. Its associated symptoms like inability to cough or talk, which also tells us about the bulbar symptoms, bulbar involvement, and the impact on sleep. So, with by gathering all this information, we would like to know whether we want to take a emergent approach, as in which one is more important, like breathlessness amounting to hypoxemia, hypercapnia, or we would have little bit time to seek more information, go with a detailed clinical examination. So then, how we go about examination in this patients in a non-emergent way. So first, we would like to see consciousness, whether the consciousness is affected or not. Sometimes, most of the times in acute neuromuscular weakness, the consciousness is spared. But then, if the patient is hypoxemic, if the patient is having a lot of hypercarbia, then the consciousness is affected. Now we grade power or strength of muscles as MRC grading, Medical Research Council grading, and not just grading the strength of muscles is important, but it is also important for us to see the distribution of weakness, whether it is proximal, whether it is distal, or whether it is both. Also, the symmetry is important, whether it is symmetrically involvement is there or asymmetrical involvement is there. Then we go ahead to the tone, whether the tone is normal or not, reflexes, whether exaggerated or depressed, and the muscle bulk, normal, atrophy, pseudo hypertrophy. Atrophied muscles are seen classically in the LMN lesions, especially in the motor neuron disease. Fasciculations again would be seen in the motor neuron disease. Cranial nerve involvement, sometimes classically seen with Guillain-Barré syndrome. Now, not just the motor system involvement, we would also like to see whether sensory system is involved or not. Again, commonly seen in the Guillain-Barré syndrome. Sometimes it would be difficult for us to assess sensory system, especially in people with depressed consciousness. Hemodynamics, heart rate, and blood pressure, because autonomic, whenever there is a polyradicular neuropathy, not just sensory system, autonomic nervous system is also involved. In subacute to chronic cases, even the gait is disturbed, and one should not forget to examine the skin, because there could be a rash when there is a dermatomyositis. There would be skin rash, heliotrope rash, bite marks, and then excessive sweating that would be visible. With by looking at the history, by looking at the examination, we would basically come to a conclusion whether it would be an upper motor neuron lesion or a lower motor neuron lesion. But in case of emergency, most of the motor neuron lesions are they act as lower motor neuron lesions. So to differentiate, the muscle tone is increased in UMN lesion. It is decreased in LMN lesion. Reflexes are exaggerated in UMN lesion. It is diminished in lower motor neuron lesion. Muscle bulk is preserved in UMN lesion, and it is atrophied in LMN lesion. fasciculations are absent in upper motor neuron lesion, and it is present characteristically in motor neuron disease, and which is involving the lower motor neurons. Now, once we see that this particular lesion is involving the lower motor neurons, then then we have to localize it further, whether it belongs to anterior horn cells, or it belongs to the root plexus nerves, or it belongs to neuromuscular junction, or it belongs to the muscle. So we have four target points for localization. So we characteristically take like pattern of weakness, sensory involvement. In this anterior horn cells, the pattern of weakness is proximal or distal, and sensory involvement would be absent. Whereas in root plexus nerves, uh, in this category, it could be proximal, it could be distal, it could be both proximal and distal, and sensory involvement is often present. In neuromuscular junction and muscle involvement, the pattern of weakness is predominantly proximal, and the sensory involvement is absent. So, what are the tools that help us? What are the investigation that helps us? So, I would like to discuss a few important things that we commonly encounter while we are evaluating these lesions. So, we can send a battery of blood tests, which includes metabolic panel, infectious disease panel, then antibodies testing we can do, and we can go ahead with electrodiagnostic tests such as nerve conduction tests and electromyography, imaging, X-rays and MRI, and biopsy in case we are not confident with the diagnosis. In so when it comes to electrodiagnostic tests, so the first diagram shows that this is an example of nerve conduction study, and the second diagram would say that it is a picture of electromyography. So we can see that in nerve conduction study, once the nerve is stimulated, there would be some time taken for the uh, amplitude to come up, so that latency is important, the amplitude is important, and the duration is important through which we calculate velocities. And when it comes to electromyography, the normal appearance would be in a triphasic wave. So there would be a negative deflection and a positive deflection. And now, based on different characteristics of nerve conduction studies, such as latency, velocities, amplitude, conduction block, temporal dispersion, F wave, and H reflex, we would like to differentiate neuropathies in terms of axonal or demyelinating. Also, we can differentiate whether it is a sensory neuropathy or motor neuropathy or a mixed neuropathy. So, axonal neuropathy, in axonal neuropathy, the predominant finding would be decreased, markedly reduced amplitude would be seen. Whereas in the predominant findings in the demyelinating disorders would be latency, which is prolonged, velocities, which would be reduced. Then, in severe cases of demyelinating disorders, we would also see conduction block. We would also see temporal dispersion. And uh, if F wave and H reflex are prolonged, it would point out at the demyelinating disorders. Now, sometimes NCS alone is not sufficient. Sometimes we would like to take help of electromyography also. So when we put the needle in the muscle, so there would be a spontaneous activity. That spontaneous activity commonly seen in the form of fibrillations and fasciculations. Fibrillations are regular activity, spontaneous activity. Fasciculations are irregular spontaneous activity. So fibrillations and fasciculations are present in axonal neuropathy, whereas in demyelinating neuropathies, they are absent. The recruitment is decreased in both, and in morphology, there would be large polyphasic waves with long duration, whereas the morphology of waves in the demyelinating neuropathies are normal. Now we combine EMG
అమ్మాయి చచ్చిపోయాడు. డెడ్ బాడీ కూడా అక్కడే ఉంటుంది.
anterior horn cells and neuromuscular junction disorders.
చంపేసిన తర్వాత ఇక్కడికి వచ్చేసిన తర్వాత ఏంటి వీళ్ళందరూ వస్తుంటారు, మంగళాశ్రీ వస్తుంది.
in
బండిసార్ పక్కనే నేను ఉంటా. మంగళాశ్రీ ఎంట్రీ అవ్వగానే నేను పుష్పరాజ్.
Hello, Glanza team. Can you please?
So like in this in order to further differentiate between anterior horn cells, neuromuscular junction, and muscle, we can use a combination of NCS and EMG. So in anterior horn cell disorders, sensory NCS and motor NCS more or less are normal, but then they might show low amplitudes as the disease progress. Whereas in EMG, we would characteristically see fibrillations, fasciculations, less recruitment, and large morphologies, like how we see how we would see in a axonal neuropathies. In neuromuscular junction, sensory NCS and motor NCS are normal, but then the motor NCS amplitudes are less in the presynaptic pathologies. In EMG is normal in neuromuscular junction disorders, especially when it is not exaggerated. Like when there is no myasthenia crisis and you test the muscle for NCS and EMG, then it would appear normal EMG. But then if the muscle is in crisis, then you would see abnormalities in the neuromuscular in the EMG. So in myopathies, sensory NCS and motor NCS are normal. In myopathies, amplitudes will be less in severe diseases. In EMG, what would you see is there would be fibrillations present, fasciculations would be absent, recruitment is normal, but the morphology of the waves are small. Now we would like to use a repetitive nerve stimulation test, especially for neuromuscular junction disorders. So we have two important neuromuscular junction disorders. There are many, but then for us, myasthenia gravis and Lambert-Eaton myasthenic syndrome, these are two important differentials. So whenever we are using repetitive nerve stimulation tests, we would like to go with slow response test and rapid response test. So whenever a slow response stimulation is being given, and if we see decremental response, it is characteristic of myasthenia gravis. Whereas if we give a rapid nerve stimulation, and if we see an incremental response, it is characteristic of Lambert-Eaton myasthenic syndrome. So sometimes when we are not sure of diagnosis still, we would like to use a single fiber electromyography. And what we would like to see with this modality is that, is there an increased jitter or not? So if there is an increased jitter, that would be diagnostic of myasthenia gravis. Sometimes patients present with symptoms which are more localized to muscles, there would be myopathies, and we can use MRI of muscles to identify the pathology, what kind of pathology we are looking at. So in this, we could see that the arrows are pointing out towards the muscle bulk, which is inflamed, whereas the arrowheads, which is pointing out around the muscles, which is showing edema. So any involvement of muscle where myositis is there, whether it is inflammatory, infective, so we can see certain changes in MRI. So not just that, we can see whether it is acute or chronic, or whether there are any secondary complications to myositis that is happening or not, we could see. Also, we can see which is an active site of inflammation that is happening in the muscle, and we can take out a sample by looking at the MRI. So these are the basic tools which will help us in understanding where the weakness is, like whether it is in the anterior horn cell, whether it is in the nerve, or whether it is in the neuromuscular junction, or whether it is in the muscle. But then, as we already told, for a patient, weakness and breathlessness both are bothering complaints. So now recently in Chest Journal, we have got a respiratory management of patients with neuromuscular weakness. An update has come. So what they have suggested is any persons with neuromuscular disease they can get PFTs done for every 6 months when the initial PFT shows uh, FVC less than 80% predicted, MIP less than 60 centimeters of water, MEP of less than 40 centimeters of water. These are the three main criteria. If these criteria are fulfilled, then the PFTs would be done every 6 months, and we would initiate NIV based on these parameters. So once we initiate NIV, and we would like to observe whether the patient is showing any other symptoms such as fatigue, headache, concentration difficulties, memory changes, weakness. So then that time we would initiate sleep studies and ABG testing. So with all of this information, we would like to comprehensively manage a patient with breathing difficulty and involvement of sleep issues. We would like to manage both of it in a comprehensive way when the patient is in the initial stages of the neuromuscular disease, where it has not progressed very much that it has become a acute breathlessness presenting to emergency. Now, we would like to talk about the emergency management of this acute neuromuscular weakness. So the initial assessment is always ABCDE for us. So in Airway, we would like to see whether the person is able to talk or not. So we would like to see whether the airway is open or not. The patient's ability to cough, the patient's ability to protrude tongue, all of this would tell whether the airway is patent or not, or whether the bulbar symptoms are present or not, whether there is a bulbar weakness or not. Then, when it comes to breathing, characteristically, when the vital capacity of a person decreases because of acute neuromuscular disease, there would be a rapid shallow breathing, there would be use of axillary muscles, there would be paradoxical breathing, and in the end, there would be a hypoxemia. So we would like to know whether this patient needs an intubation or not. We would do a single breath count. We would see how the single breath count in the coming slides. Not just breathing, we would like to see circulation. We would like to look at the presence of hypertension, hypotension, or arrhythmias. Hypertension and arrhythmias are common findings in Guillain-Barré syndrome, and in a chronic patient who has neuromuscular weakness, has aspirated, would present to us in hypotension because of the sepsis that is caused by aspiration pneumonia. Then we would like to see the if there is any problem with the consciousness. We would like to see pupils, and more importantly, the pattern of muscle weakness, which would give us an idea as in what kind of problem we are dealing with. So exposure, hypothermia, and hyperthermia both would be seen. Now, what happens with breathing difficulties in neuromuscular disease is that there would be a rapid shallow breathing. There would be a decreased ventilatory response to hypoxic or hypercapnia challenge, whereas P0.1, which is independent of the central respiratory drive, would be normal. There would be a decreased vital capacity, inspiratory capacity, FRC, and expiratory reserve volume, but the residual volume would be maintained. Along with the breathing difficulties, there would be sleep disturbances also, because in the REM sleep, the tone of muscles would be reduced. So already the patient is experiencing acute neuromuscular weakness. And with this kind of neuromuscular weakness in the sleep, during REM sleep, if there is further decrease in tone, it would exacerbate his hypoventilation issues or the patient's hypoxemia issues. So that would lead to frequent nocturnal desaturations and hypercapnia. So whenever we are looking at breathing, it is also important for us to look at the quality of sleep. Now, we would like to know whether we should intubate a patient with neuromuscular weakness or not. So ideally, in any given patient, we can give a trial of NIV when there is a respiratory distress. But then certain things should alarm us or should make us alert regarding the necessity of intubation. So one such feature would be the history, shorter duration of hospitalization from symptom onset, which is at least 3 to 7 days onset to hospitalization from this symptom onset. Then there is a bulbar or facial weakness. So inability to protrude tongue out, inability to handle oral secretions, dysarthria, dysphonia, all these point out like towards bulbar or facial weakness. And if a single breath count is less than 13, so then that would point out that vital capacity is very low. Neck flexor strength is less than 3. Paradoxical breathing is present. And if at all PFTs have been done, vital capacity less than or equal to 20 ml per kg would be alerting us that this patient might require intubation sooner or later. So in the given points, no single metric is sufficiently sensitive or specific to predict whether this patient requires ventilator support or not. So we need a multimodal approach. So we need to take history, we need to do examination, and whenever possible PFTs in the emergency. So a multimodal approach would help us in predicting the requirement of intubation much better than a single test. So, but more importantly, not just multimodal approach, multiple serial evaluations are required, because at this moment patient would be fine, but in some time the patient might deteriorate and would be requiring intubation. So for us, it is important for us to have a serial evaluation. So at least 4 hourly serial evaluations are required. Now we have something called as Erasmus Guillain-Barré syndrome respiratory insufficiency score, EGRIS tool. So this EGRIS tool is something used to predict whether mechanical ventilation would be required or not within the 1 week. So the score includes days from symptom onset to hospital admission, presence of facial or bulbar weakness at the admission, overall weakness severity as measured by MRC score. The MRC sum score looks at 3 upper limb muscles and 3 lower limb muscles. So the 3 upper limb muscles would be deltoid, biceps, and wrist extensors, whereas 3 lower limb would be hip flexors, knee extensors, and ankle dorsiflexors. So they add the MRC scoring of each muscle group, and the total MRC sum score would be 60. Out of 60, they would give us a score. So we could see in the diagram that the points have been given. The shorter the onset of to the admission, from the onset of symptom to the admission, the shorter the duration, the more points we get, and the more MRC sum score. Like the less the MRC sum score, the more number of points we are getting, and the more number of points EGRIS total score would be, the more chances of probability of getting requiring a mechanical ventilation within 1 week. Now, once we have decided that this patient would require intubation because the patient is having a very short duration of onset of symptom to the hospitalization, because the single breath count is less than 13, or there is bulbar weakness, there is increased oral secretions which the patient is unable to handle. So we have decided to intubate this patient, but then we need to take certain precautions. Suppose if we think this patient is probably having a Guillain-Barré syndrome, then there is a risk of dysautonomia, where your intubation might exaggerate hemodynamics. Then we would also need to understand that this would impact the way of intubation. So if we want to make the person lie down, the person won't be able to lie down, because in neuromuscular weakness, characteristically, patient won't be able to lie down supine. So patient would experience orthopnea, and patient breathlessness would be bit relieved when the patient sits back from the supine position. So for us to position the patient for intubation and give pre-oxygenation, it would be difficult. Then by the time we intubate, patient would have aspirated. So this would form a physiologically difficult airway. And the choice of drugs. So if we give propofol, there might be a sudden fall in blood pressure. If we give ketamine, there would be exaggerated hemodynamic responses. So it would affect our choices of drugs. And also, we should be mindful in choosing a paralytic agent. So succinylcholine is a big no in intubating these patients. So because in myasthenia gravis, patients would be resistant to succinylcholine, whereas in Guillain-Barré syndrome, there would be a risk of hyperkalemia. So it's always advisable for us to use a low dose non-depolarizing agent. So by taking all these precautions, we would like to electively intubate a patient, not when the patient is crashing. It's always ideal to intubate a patient electively. So we would take all these precautions. Now, once an airway is secured and we have initiated mechanical ventilation for him, we would see how we would like to take care of mechanical ventilation. But then in the airway topic, another concern for us is, should we go to early tracheostomy or late tracheostomy? So still the consensus have not like the consensus are not for or against early or late tracheostomy. So we need to consider on individual basis, and more importantly, the trajectory of underlying illness. Like for example, my patient coming with myasthenia crisis, the myasthenia crisis could be managed with a bout of steroids, with a bout of plasmapheresis and IVIG, and the crisis would be sorted out sooner or later within 7 to 10 days, and patient might get extubated. So myasthenia gravis in crisis may not require most of the times, but some patients do require prolonged ventilation. Whereas in Guillain-Barré syndrome, this would, the trajectory of illness would go more or less up to 4 weeks. Whereas a motor neuron disease coming in acute exacerbation of breathlessness requiring an intubation, so patient would take forever to come out of the intubation. So we need to understand that the nature of illness is important, the trajectory of underlying illness is important, and the patient's requirements. All these things we need to take into consideration before going ahead for the tracheostomy. So even though we want to do an early tracheostomy, there is no mortality benefit, but then we do have theoretical benefits such as less sedation, less delirium, fewer mechanical ventilation days, less incidence of pneumonia, and more importantly, patient's comfort. So as I said, characteristically, if there is no sepsis and no CNS involvement, so many of the times the patients are fully awake. So people perceive that if we do a tracheostomy, it would be easy for us to, push the patient for rehabilitation, and the recovery would be fast. So we have one study where it is a retrospective observational study. So they have seen whether there is any benefit of early tracheostomy uh, in Guillain-Barré syndrome patients requiring mechanical ventilation. For them, early tracheostomy is within 1 week. What they found is there is no difference in in-hospital mortality and 28-day mortality. Also, there is no difference in incidence of nosocomial pneumonia. So I mean, we should take a call based on case to case basis about the tracheostomy and ventilation strategies. I couldn't get any specific guidelines as in how we should go about the ventilation strategies. So when it comes to the mode, whether it is a pressure control mode or volume control mode in the initial phases of mechanical ventilation, uh, there is no evidence of preferring pressure control over volume control. But now the new mode of pressure regulated volume control has come. So it has the characteristics of both pressure control and volume control. So it might bring the advantages of both pressure control and volume control for the patient. Tidal volume, as always, 6 to 8 ml per kg of predicted body weight. These patients would have low compliance, whether it is lung or chest. So adequate PEEP should be given to counter this low compliance. And once the patient is out from the acute phase, then we would like to wean the patient And in the weaning, pressure support ventilation would be helpful. And once we decide that the patient would be difficult, patient would have a difficulty in weaning, and we are unable to wean the patient off from the ventilator, we would like to suggest home ventilation through BiPAP machines. So now there is new modes have come in the home BiPAP machines, which is volume assure pressure support. So when compared to the pressure support mode, it is delivering a consistent tidal volumes and lower respiratory rates. So if we are choosing home ventilation BiPAP strategy, VAPs would be a better choice, according to a small study given in the Fishman's book. So now we understand that we have ventilated the patient and patient is recovering from the acute phase of illness. So now our role comes in weaning. So we need to understand that weaning starts when the primary pathology has been taken care of adequately, and new complications have been prevented or managed, such as atelectasis, VAP, excessive secretions in the bronchial tree. So for excessive secretions in the bronchial tree, we would need aggressive pulmonary rehabilitation. So we would need, once these are taken care of, we would also in parallel giving the patient sedation holidays and spontaneous breathing trial. And suppose like the patients of myasthenia gravis or um, uh, any like snake bite, organophosphorus, where the patient would come out of illness much easier. So we can extubate the patient to NIV or HFNC. Also, we need to understand that before extubation, we need to look at ability to lift and hold their head off the bed, generate a cough, tolerate a spontaneous breathing trial, and minimal oral and endotracheal secretions would be good for extubation. And one important thing which I forgot to add in the slide is that when it comes to Guillain-Barré syndrome, because of autonomic involvement, so patient would be experiencing frequent bronchospasms. So when during the recovery, initially autonomic symptoms would first wean off. So that would help us in getting control over the secretions part, bronchospasm part. Then slowly the diaphragm weakness would be initially recovered when compared to the truncal muscles. So we might consider weaning off Guillain-Barré syndrome patients a bit early, whenever we see the sign of hemodynamics getting settled for this patient. So when we talk about hemodynamics, invasive hemodynamic monitoring is a must. Arterial line is a must, because the hemodynamics are very labile in the form of hypertension and arrhythmias. Sometimes it is so labile that it could push the patient to Takotsubo cardiomyopathy or PRES, posterior reversible encephalopathy. The reason for this would be baroreceptor sensitivity due to vagal denervation is considered as a possible mechanism for this labile hemodynamics. So in this case, we would not like to go ahead with the long-acting antihypertensives, but short-acting antihypertensives are recommended. So to help us in the management, point-of-care ultrasound of diaphragm has come to rescue. So what we can do with point-of-care ultrasound diaphragm is that we would like to see whether there is diaphragmatic thickness, how much the diaphragm thickness is at the inspiration or expiration, calculate diaphragmatic thickness fraction. Also, at the same time, we would like to see if there is any paradoxical movement. So you can see the last pick, the D pick. So it is showing a paradoxical breathing. There is a dip. Instead of going up, there is a slight dip. So through ultrasound, we can see whether there is an paradoxical movement of diaphragm or not. We would like to see whether the acute neuromuscular weakness has impacted diaphragm in terms of reduced diaphragmatic thickness. Then we would like to see whether there is a good excursion or not. So we can see diaphragmatic excursion. Also, we can use a sigh maneuver. Like we would like to ask the patient to cough or take a deep breath. So then, looking at the morphology of diaphragm excursion, we can say whether the diaphragm is functioning or not. So not just this diaphragm point of care ultrasound, we can do point of care ultrasound for extra diaphragmatic respiratory muscles like parasternal intercostal muscles and the abdominal muscles. So they say that usually parasternal intercostal muscles are not involved in a quiet breathing, but then when they are recruited because of respiratory distress, you would see the same thing as you have seen in the diaphragm, like during inspiration, there would be increase in thickness of diaphragm. The same way, when these muscles are recruited during inspiration, there would be an increase in thickness fraction. So, whereas for the abdominal muscles, they would be also recruited, and then you can see how the muscles are acting in the respiratory distress, whether they are actively contracting or not, how is their thickness fraction, you can see. So based on all these things, you can estimate whether there is any recruitment of additional inspiratory muscles or expiratory muscles, abdominal muscles in the respiration or not, you would see. Also, you would see how expiratory muscles are behaving. So sometimes if expiratory muscles are wasted because of critical illness, then there would be difficulty in weaning. So all these things can be estimated from point of care ultrasound. So now point of care ultrasound is important, but pulmonary rehabilitation is equally important. So the three P's: point of care ultrasound, pulmonary rehabilitation, and the palliation, which comes next. So these three are equally important modalities which will help the patient to recover in a much better way. So aggressive pulmonary rehabilitation in the lines of sialorium management in the form of oral anticholinergics, botulinum toxin injections, salivary gland radiotherapy would help patients to keep the oral secretions in control. Although these pulmonary rehabilitation, the methods are mixed up. Like some of them are used in a non-emergent settings. Some are used in the ICU. So, like glossopharyngeal breathing technique, manually assisted cough techniques, mechanical insufflation, exsufflation techniques, or high frequency chest wall oscillation devices. These are the other techniques which are used for pulmonary rehabilitation, a glimpse of which you can see in these images. So, the first picture is the resuscitator bag, which is used to stack breaths. So it increases the lung volumes and thereby increases the cough flow. So this is one of the methods of manually assisted cough technique. And in the picture B, you would see that a machine is being used, so which is mechanical insufflator, exsufflator. So now palliative care is important. Palliative care doesn't equate to end of life care. So it is important for us to understand this important concept that palliative care is not end of life care. So palliative care uh, takes care of all domains of patient suffering. So which could be physical, psychological, social, emotional. So all these things are being taken care of. Now the palliative care is being advocated to be involved early in the management of disease. So the earlier you involve palliative care team, the better would be there would be a better response in managing such cases. So then finally we come to three notorious things which we commonly find in ICU. So one is critical illness, myopathy or polyneuropathy, or commonly called as ICU-acquired weakness. Then we would see very briefly about Guillain-Barré syndrome and very briefly about myasthenia gravis, and we would end the seminar here. So when it comes to critical illness, myopathy or polyneuropathy, we had one patient who is elderly lady who has developed cellulitis, then ARDS, shifted to ICU for further management, and then the patient was ventilated for ARDS, prone multiple times, was kept on steroids, was kept on neuromuscular blockade drugs. So we were very happy. Attendants were very happy that the ARDS was managed very well. Now, both the parties are happy, but then what happened was by the time we want to wean this patient off and extubate, the patient had difficulty in weaning, and then we have seen that the patient has a flaccid quadriparesis. So now this is a new finding, and the patient relatives thought that patient is on road of recovery and is soon, coming home. But then, to our surprise, it is the other way around. So then the reason is the critical illness myopathy or polyneuropathy or ICU-acquired weakness. So it is a common thing which we see in ICU in sick patients where there is good sepsis for which we have used multiple medications, and by the time patient recovers, there will be a problem which we call it as ICU-acquired weakness. So now there are two forms of ICU-acquired weakness broadly. It could be a critical illness polyneuropathy. It could be critical illness myopathy. So both present initially as difficulty in weaning from the ventilator once the sedation has been taken off. And we would like to see whether there are any pulmonary causes for it, cardiac causes for it, but we would not find much. So then we need to suspect critical illness polyneuropathy or myopathy. Also, we would see symmetrically flaccid involvement of proximal and distal muscles with absent reflexes. So these two are common presentations, and in critical illness polyneuropathy, there would be acute axonal sensory motor polyneuropathy, the predominant uh, pathogenesis, whereas in critical illness myopathy, it is acute primary myopathy, and the pathogenesis would be normal histology to muscle atrophy and necrosis would be seen. So when we go and likely to would like to understand the pathogenesis, why this is happening. This is because of sepsis related alteration in microcirculation of peripheral nerves. So the cytokines get released because of sepsis. That cytokines cause increased vascular permeability. Then it would cause direct toxic effects on the muscle or nerve walls. So there will be selective degradation of myosin heavy chains in case of myopathy. There will be hypoexcitability of muscle cell membranes, alterations in excitation, contraction, coupling mechanisms, and free radical damage. So, because of all these things, like patients would experience critical illness polyneuropathy or critical illness myopathy. So there is a old diagnostic criteria for this. For any patient who is developing generalized weakness after the onset of critical illness, and the weakness is diffuse, involving both proximal and distal muscles. They are symmetric, they are flaccid, and we usually don't see cranial nerves. Like, and when we see the MRC score, it would be less than 48 or mean score of less than 4 in all testable groups, noted on more than or equal to 2 occasions separated by more than 24 hours. There is a dependence on mechanical ventilation, and the causes of weakness are not related. Uh, uh, Causes of weakness not related to underlying critical illness have been excluded. So the minimum criteria which is required is criteria 1, 2, 3 or 4 and 5. So the in the previous slide in the diagnostic criteria, we have seen that the causes of weakness not related to underlying critical illness have been excluded. So we would like to see the differential diagnosis in the form of mnemonic muscles. So the medications which we use commonly steroids, neuromuscular blockades, zidovudin, amiodarone, sometimes magnesium. So uh, these would uh, um, these would cause muscular weakness. Previously undiagnosed neuromuscular disorder. So previously, patient would be having a myasthenia gravis, which got exacerbated or went into crisis because of the current illness. A spinal cord disease, trauma to it, or a demyelination to it, which got precipitated because of critical illness. Uh, then there is a loss of muscle mass because of rhabdomyolysis secondary to infections, or cachexia that is happening because of malnutrition. Then electrolyte disorders such as hypokalemia, hypophosphatemia, and hypermagnesemia. Also, some systemic illness, porphyria, vasculitis, paraneoplastic syndromes. So these are like common causes of acquired muscular weakness in an ICU setting. Now, we'll briefly discuss about Guillain-Barré syndrome. As we all know, Guillain-Barré syndrome would be suspected when there is weakness uh, because of an antecedent, because of a preceding event such as infection. So there is a acute onset of weakness on bilateral lower limbs to start or upper limbs to start with, and it will progress ascending. Ascendingly, it will have a facial palsy, it will have ophthalmoplegia or ataxia. And at this point of time, patient would also have sensory symptoms such as tinkling, pain, paresthesias. Also, patient would have an autonomic symptoms. And when such things happen, we would like to diagnose Guillain-Barré syndrome based on a combination of CSF findings, NCS, electromyography findings. Uh, so once we feel like, okay, this is Guillain-Barré syndrome, we are going to admit that case in ICU. When there is rapid progression of weakness, involvement of bulbar muscles, aggregate score of more than 4, we would be admitting it to ICU, and immediately, as early as possible, we would be starting the treatment in the form of either IVIG or plasma exchange. So, IVIG 0.4 gram per kg daily for 5 days, or plasma exchange 200 to 250 ml per kg for 5 sessions. So, we start the treatment, and then we would like to monitor uh, whether the patient is coming out of the weakness or not. We would like to take care of hemodynamics, and we also want to look at the early complications. So, as I told, there would be arrhythmias, hypertension, which would be pushing to Takotsubo cardiomyopathy and then press. Not just that, patient would experience paralytic ileus, and if it is not taken care adequately, it might lead to perforation also. Uh, Not just these specific GBS problems, also we would like to take care of other common ICU problems such as DVT, pain, urinary retention, pressure ulcers, etc. So we would see whether the clinical picture is progressing or not, and then based on the trajectory of illness, we would like to plan long-term care in the form of rehabilitation. So, myasthenia gravis characteristically presents with fatigability. So, whenever clinical history and examination points out that patients are likely to have myasthenia, especially when patients complain that in the morning they're fine, and by the evening, because of the work and all, they would experience weakness, especially ocular weakness, ptosis is there. So that is when we suspect myasthenia gravis, and then we would do ice pack test. Then we would send for some antibodies, acetylcholine receptor binding antibody. Then we would like also to send anti-musk. Then we would like to do slow rate repetitive nerve stimulation test, single fiber EMG test, and based on all the findings, we would like to see whether it is a myasthenia gravis or not. And if all of these are negative, it is unlikely myasthenia gravis. It would be something else. But once myasthenia gravis is confirmed, then we would like to plan whether this patient is eligible for thymectomy or not. And then we would like to start um, pyridostigmine. Then we would like to see the response with pyridostigmine. And if the patient is pushed into crisis, we would be giving him a combination of steroids plus or minus IVIG or plasmapheresis. And this is how we manage myasthenia gravis. Thank you.
Thank you, Mohan.
Uh, Sir, I thought I would cover as much as possible among the general topics, because this GBS and myasthenia gravis, more or less, we would hear most of the times and we would read most of the times. So I thought
Yes.
I've gone in this way. I hope.
No, thank you, Mohan. It was quite extensive, but at the same time, the approach, the initial part where you kind of try to look at highlight the various aspects of how do we approach diagnosing a patient with acute neuromuscular weakness is quite important because it can sometimes be very challenging, confusing. Many a time you may not be able to get a pinpoint diagnosis, and many a time we rely on first the initial management, supportive care, and then probably establish a diagnosis retrospectively. So thank you very much. I think that was something was very, very clear, especially about how to look at various investigations. How do you interpret and you know the classifying or simplifying the whole thing in the tabular form. I think that will be very, very useful for most of the residents, even to us, because simply looking at the tabular form and trying to put the different investigations into those columns can help you come to a diagnosis. It's not a specific name, but at least a syndromic diagnosis of where the problem is.
I would like to thank you also, sir. Like for me, I'm interested in neurosciences. For my interest would be more of a traumatic brain injury, then stroke. Whenever a case of acute neuromuscular weakness comes, I would be like, no, I'm not very good at this, so I'm not going to, go very deep into this. So this was my attitude. But then once the topic is given, I made sure that this is the right opportunity to read, learn, and understand about this topic, and that helped me to make all these tables not just for audience or for the other residents, for myself also. So this would be a uh, precious exercise for me to learn and understand.
Thank you, Mohan. Thank you once again. Thank you all. If you have any queries, please do write to us. We will get back to you with the solutions, and I will see you next week. Thank you so much, Mohan.
Thank you, sir.